back to my channel. And today I'm going to discuss some topics from infectious disease part of pediatric chapter Toronto Notes 2025 edition. So let's start. The first topic I'm going to cover today is called acute otitis media, means acute infection in the middle ear. So it includes all of the things, including middle ear effusion, middle ear inflammation, acute onset of symptoms of middle ear effusion as well as inflammation. Okay, so we need to remember that infection can lead to inflammation as well as effusion. So this is basically both effusion or inflammation or both. So what happens that 6 to 24 months is the most common age group. Okay, commonly develops within a week after a viral upper respiratory tract infection. We are commonly seen that sometimes after a viral upper respiratory tract infection, children complain that they have got some pain in the ear, some discharge coming from the ear. That can be a sign of acute otitis media. Okay, and it's very much common in children. They have more than 3 episodes by the age of 3. And the peak incidence is definitely in the winter season that extends from January to April. Okay. Now the etiology, the bacteria that we need to keep in mind causing acute otitis media includes number 1 is Streptococcus pneumoniae, number 2 H influenza, and number 3 Moraxella catarrhalis. Okay, so Streptococcus pneumoniae, H influenza, Moraxella catarrhalis, and group A Streptococcus. I think the most common among them, if somebody asks us in the MCQ, the most common is Streptococcus pneumoniae, but they say the incidence is decreasing since introduction of vaccine. So I think H influenza is on the top, then Streptococcus pneumoniae, then Moraxella catarrhalis, and group A Streptococcus. But there are just 4 bacteria. We need to remember the names. And the less common are basically anaerobes, which are more common in newborns, and the gram negative enteritis is more common in infants. Okay, so in newborns, the more less common are basically anaerobes, and the gram negative enterics are more common in infants. Okay, so viral cause is more likely to spontaneously resolve. Respiratory syncytial virus is a common virus that can cause viral acute otitis media. Also, there can be other viruses like coronavirus as well as the flu virus. Okay, so the respiratory syncytial virus, influenza virus, and the coronavirus, 3 viruses and 4 bacteria we need to remember. Okay, now the risk factors are basically eustachian tube related. Okay, the eustachian tube is the tube that connects the external ear to the middle ear. So the is either dysfunction or obstruction. Okay, if it's not functioning properly, that's called dysfunction, or either there is obstruction in the eustachian tube. There may be upper respiratory tract infection. There may be allergic rhinitis, chronic rhinosinusitis, adenoid hypertrophy, and barotrauma. So these are basically related to eustachian tube, that is basically obstruction of the eustachian tube, and these include upper respiratory tract infection, allergic rhinitis, chronic rhinosinusitis. So allergic rhinitis, if there is allergic rhinitis, basically sneezing and allergic symptoms, rhinosinusitis, adenoid hypertrophy, so basically infections in the ENT area, and barotrauma as well. Okay, inadequate tensor villi palatina and cleft palate. Simple terms, cleft palate can cause it can be a risk factor for acute otitis media. Okay, the other risk factors include maybe genetic syndromes like the Down syndrome. That is nice. Just remember the Down syndrome. That's it. Then the cilia disruption causes maybe Carter-Jenner syndrome. Okay, Carter-Jenner syndrome. There is a ciliary immortality, and as a result of that, there is eustachian tube does not function properly. Okay, and as a result of that, there can be risk factor for infection. Genetic predisposition, again, of course, it can run in families. Family history can be there. Ethnicity, First Nation peoples, and Inuit more common. Okay, or and the next thing is behavioral and environmental exposures, especially the children who are not breastfed or shorter duration of breastfeeding. Okay, so breastfeeding can be a protective factor against acute middle ear infection. And the prolonged bottle feeding, if the child is bottle fed and not taking the breastfeed, that can be a risk factor for acute middle ear infection. And the bottle feeding, especially if is done in the laying down position, all right, and the use of pacifier can be the risk factor. Second hand smoke exposure, very important. That's why it's highly recommended when a newborn child is in the room. Any person who smokes should change his clothes, should not come near the child, because even the second hand exposure of smoke is very dangerous to the infant, the newborn child, the neonates, and it can lead to even the respiratory distress syndrome, sudden infant distress syndrome, and also can lead to this condition called acute otitis media. Crowded living condition or daycare, and the sick contacts. The immunosuppression or deficiency includes certain use of certain chemotherapeutic agents, steroids, which are immunosuppressants, diabetes, and hypogammaglobulinemia, as well as cystic fibrosis in children. Okay, now the next thing is, first what we have to see that we don't need to know the pathogenesis in detail, just we need to remember the clinical features. The symptoms will be acute. There is a triad of otalgia. Otalgia simply means pain in the ear. Best predictor of acute otitis media, the child always presents with pain in the ear. There may be fever, especially in young children, and there may be conductive hearing loss. Okay, and they say that not all the symptoms like fever or hearing loss may be present at the same time. Rarely they can be ringing in the ear called tinnitus, vertigo, or facial nerve paralysis. Okay, so there can be other features like maybe ringing in the ear, but is rare. Vertigo, dizziness is rare, or facial nerve paralysis is rare. Otorrhea, that is discharge from the ear if tympanic membrane is perforated. Infants or toddlers, okay, now see the infants which are very small children and toddlers up till 1 to 3 years of age are toddlers. They cannot tell that they have pain in the ear. What they're gonna do? They're gonna do ear tugging. Okay, then they can present with hearing loss, balance disturbance, but is quite rare. They can be especially irritable. Okay, remember, if a child is having fever, he is not hearing well, he is having pain in the ear, he is not sleeping well, he is irritable, maybe there can be vomiting and diarrhea as well, and there can be loss of appetite because the child is not able to take his feed as usual. Okay, now the otoscopy of tympanic membrane basically can show hyperemia, that is redness of the tympanic membrane. There will be bulging tympanic membrane, and the pus may be seen behind the tympanic membrane. Otoscopy findings are very much important. Remember, this is infection, this is inflammation, this can be effusion, so all these things can be seen while otoscopy, and there can be redness on the tympanic membrane, there can be bulging tympanic membrane, and the pus can be seen behind the tympanic membrane. There may be loss of landmarks like handle and long process of malleus are not visible, and there can be discoloration, hemorrhage, and gray, red, and yellow color. Diagnosis requires middle ear effusion and signs of inflammation. Okay, accurate diagnosis of acute otitis media is very important. Okay, to prevent antibiotic overuse, because we need to know that in children most cases are viral, so we don't need to give antibiotics if it's a case of a viral acute otitis media. Okay, now I can see a clinical something here on the side, and this shows that management of acute otitis media in children 6 months of age and older. So what they say that the milder disease is usually due to viruses, as I already told you, in infants, very young children, 6 months of age and older, very virus is the most common cause of illness. Okay, or maybe the low virulence bacteria resolves quickly because it's viral with or without antibiotics. Okay, now the features may be bulging tympanic membrane, especially on otoscopy, okay, and has a high sensitivity to acute otitis media, and is a major diagnostic criterion, likely bacterial. Okay, so if there's a bulging tympanic membrane, and can be bacterial as well. So perforation of tympanic membrane with purulent discharge, acute, indicates bacterial otitis media. So we need to remember that how to differentiate between the viral acute otitis media and the bacterial acute otitis media. The viral will be simple fever, there may be pain in the ear, child will be irritable, crying, fussy, not feeling well, all these things, but low grade fever will be there, not very high grade fever. And but on otoscopy, maybe there's maybe some tympanic membrane redness, but especially if there's a bulging tympanic membrane, especially if it's hemorrhagic or yellow, and so it can be bacterial. And especially if you see in otoscopy that there's a perforation of the tympanic membrane, means that tympanic membrane has a hole and there's a discharge coming which is looks purulent, so indicates bacterial. Okay, now the indications for immediate antibiotic treatment. What are the indications if the temperature is very high? High grade fever is there, more than 39 degrees centigrade. Moderately to severely systemic illness, so systemically child is not well. Then very severe otalgia, means severe pain in the ear and significant illness for at least 2 days. Okay, so these are some of the indications for immediate antibiotics. Okay, child comes to you with a high grade fever and significantly ill for last 2 days, not eating well, not feeling well, and severe pain, constantly pulling or tugging his or her ears. So we can see that we need to give some antibiotics for that reason. Okay, and this is an indication for antibiotics. Okay, now what antibiotics are given to the children? They are mainly given amoxicillin, that is clearly the drug of choice. So remember, antibiotic for acute otitis media, amoxicillin we should remember, that is the antibiotic of choice for acute otitis media. Okay, how many days we should give amoxicillin? 10-day course for children if it's less than 2 years, and 5-day course for children more than 2 years. So if the child is less than 2-year old, we have to give for 10 whole days, and if the child is more than or equal to 2 years, then we can give for 5 days. Okay, and for milder presentations, plan a reassessment at 48 hours. Okay, we can reassess the child at 48 hours if the case is mild. Provide antibiotic prescription to parents to fill if the child does not improve in 48 hours. So they mean to say that if there is a mild presentation, child is not extremely unwell, and so what we can say, we can see this expectant, we can do this expectant approach. We have to keep the child under observation, and we have to say the parents that we have to bring the child 48 hours if the child does not feel better. Or the second thing is, we have to provide antibiotic prescription to the parents, and they can fill it if the child does not get better in the next 48 hours. Okay, next thing is management. Again, I think is more detailed management given here. Symptomatic management, especially if the child is suffering from fever and pain, give antipyretics, fever medication, analgesic painkillers. Watchful waiting if the criteria is met. Antibiotic therapy if less than 6 months. If especially as we read already in the above table as well, that the child if is less than 6 months, so less than 6 months, that is a something serious, right? So what we have to do, and he's suffering from moderate severe illness, we have to give antibiotics. Between 6 months and 3 years, we have to see some other criteria need to be fulfilled. But if the child is just less than 6 months and is suffering from moderate severe illness, okay, moderate or severe illness, what we have to give, high dose amoxicillin, and we don't need to remember the doses, that is given for 5 days and 10 days if the age is less than 2 years. Okay, perforated tympanic membrane or recurrent otitis media, if penicillin allergic, give cefuroxime, ceftriaxone. Okay, that much we need to remember. Amoxicillin, first line antibiotic. If allergy to amoxicillin, then we have to give cefuroxime and ceftriaxone. Okay, then the second line is amoxicillin clavulanic acid. Amoxicillin along with clavulanic acid, that is the second line. Also cephalosporins are the second line, cefuroxime, ceftriaxone, cefaclor, all these cephalosporins are second line. So amoxicillin is always the first line. Amoxicillin along with clavulanic acid as well as cephalosporins is always the second line. Now, these antibiotics are used when acute otitis media is unresponsive and clinical sign and symptom persist beyond 48 hours of antibiotic treatment or for treatment of otitis conjunctivitis syndrome. So, along with otitis, there can be conjunctivitis as well. Means the child eyes get watery and there can be some discharge coming from the eyes. So, if the symptoms persist beyond 48 hours, we have to switch to antibiotics. Okay, and okay, then the signs of a perforated tympanic membrane should always be treated with antibiotic therapy. If we see that and we do otoscopy of the child, and we see that the tympanic membrane has a hole, so we should treat with antibiotics. Okay, most commonly topical antibiotics like ciprofloxacin and dexamethasone. Okay, if the child has a perforated tympanic membrane, now we switch, instead of oral antibiotics we give topical antibiotics. Okay, topical antibiotics including ciprofloxacin, that is of fluoroquinolone, and dexamethasone, and examine for complications. Okay, now prevention. Parent education again is very much important about the risk factors. Pneumococcal and flu vaccines can be protective in nature. Okay, and surgery, for example, tympanostomy tubes can prevent recurrent infections. Okay, the choice of surgical therapy for recurrent otitis media depends on whether local factors, either eustachian tube dysfunction, are responsible. Use ventilation tubes. Okay, or regional disease factors, tonsillitis, adenoid or sinusitis are responsible. So the basically they mean to say that whatever is the risk factor for recurrent acute otitis media, we have to treat that risk factor. Okay, if the child is having eustachian tube dysfunction, okay, so we have to use ventilation tubes. Eustachian tube is not functioning properly, we have to use ventilation tubes. If there are regional factors, like if their child is suffering from tonsillitis, we have to do tonsillectomy. Adenoid hypertrophy, adenoidectomy. Sinusitis must be treated. So if the treat the underlying risk factors, definitely we can treat this condition. And for once for all, like once we treat the risk factors, definitely this disease gonna the child will get rid of this disease for a long time. Okay, now the complications of acute otitis media: extracranial, there may be hearing loss, there may be speech delay because of the middle ear effusion. Tympanic membrane perforation can happen, as we already know. Extension of the suppurative process to adjacent structures means the pus formation can go to the adjacent structures. There can be mastoiditis, inflammation of the mastoid process of the bone of mastoid bone, that is behind the ear. There is a bone called the mastoid bone, petrositis petro. So there may be some inflammation of the structures behind the ear. There may be labyrinthitis, petrositis, mastoiditis, or their adjacent structures to the ear, and this can be a dangerous condition as well. Also, there can be cholesteatoma, facial nerve palsy, middle ear atelectasis, necrosis of the bones of the middle ear, vestibular dysfunction. Okay, so the next are the intracranial complications of acute middle ear infection. There can be meningitis, that is very dangerous, epidural, and the brain abscess formation. Okay, then the subdural empyema. Okay, and the lateral and the cavernous sinus thrombosis and the carotid artery thrombosis. Okay, so the complication of idea is that we have to think about two types of complications can happen: extracranial, outside the brain, not involving the brain, and intracranial, involving the brain. So extracranial include involvement of the ear, And then there can be speech problems, there can be perforation of tympanic membrane, there can be bone involvement, mastocytis, petrositis, there can be nerves involvement, facial nerve palsy, and there can be necrosis of the ossicular bones of the middle ear. Now, the intracranial complications include infections like meningitis, abscess formation, empyema, localized collection of pus, okay, and the cavernous sinus thrombosis or the carotid artery thrombosis. All right, now is a very comprehensive table that shows management of acute otitis media, and after that we will finish our today's session. Okay, acute otitis media is a very important topic. That's why I took much time to describe all the details written here in Toronto notes. Okay, now the management of acute otitis media. As we already know, if the child is less than 6 months of age, generally healthy, acute illness is there with or without fever, okay, and may not manifest other signs of middle ear dysfunction. Depending on age and verbal skills, we are just suspecting acute otitis media. Okay, but the age is less than age is more than 6 months. Okay, as we already know, if the age is less than 6 months, we are not reluctant in starting antibiotics. Okay, and the child is suffering from any moderate or severe illness, so we start antibiotics right away. But if the age is between 6 months and 3 years or more than 6 months, so we have to look at all these things. But if we have to see otoscopy, and on otoscopy we find a perforated tympanic membrane and the pus is coming, pleural discharge is coming, we have to treat with antibiotics definitely for 10 days. Okay, so, always remember, if there is, so the criteria says that if the age is more than 6 months, is perforation of tympanic membrane, discharge coming from the ear, always treat antibiotics with antibiotics for 10 days. Okay, now if there's suspicion, but when we see otoscopy, we see the middle ear effusion and the bulging of tympanic membrane. Then what we're gonna see whether the child is mildly ill or moderately or severely ill. Okay, what happen if the child is mild ill? If the child is alert, child is responsive, no high grade fever, responding to antipyretics like acetaminophen, ibuprofen for pain, able to sleep, okay, and no high grade fever and less than 2 days. So after discussion with caregivers, observation for 48 hours is recommended and ensure follow up. Okay, we just give acetaminophen, ibuprofen, and we just have to recommend follow up after 2 days. If not improved of the worsening, then we treat with antibiotic for 10 days. Okay, so we can give a prescription to the parents and tell them that the child, if it gets better within 2 days by use of painkillers, and child is sleeping well, eating well, and fever doesn't get high grade, and child is getting better with antipyretic and painkiller, so don't need to start antibiotics. But if the child does not get better in 48 hours, then we have to switch to antibiotics. Okay, and antibiotics should be given for 10 days if the child is between 6 months to 2 year of age. Always remember, less than 2 year or less than 2 year, we have to give antibiotic for 10 days, and 5 days if the child is more than or equal to 2 years of age. These are very important guidelines we need to remember. Okay, I hope you guys understand them well. Okay, now move towards, if the child condition was, on otoscopy, we see that there was effusion present and there was a bulging of tympanic membrane, and the child is moderately or severely ill, very irritable, cannot sleep properly, does not respond to the fever medications, and shows severe signs and symptoms of ear pain, and also he is suffering from high grade fever. Okay, and there are more than 48 hours, then we have to definitely start antibiotics right away. Okay, and again the same criteria, less than 6 months for 10 days, and for 5 days in more than equal to 2 years. So these things and these things, you can just remember the same thing for both of them. So whenever antibiotics is needed, 10 days if less than 2 year of age, and between 6 months and 2 years is 10 days, and for 5 days is more than equal to 2 years. Okay, now you look at the tympanic membrane of the child, you do otoscopy, and you see nothing. There is no middle ear effusion, or with middle ear effusion but non-bulging or mildly red tympanic membrane. The tympanic membrane is not bulging, or there is no effusion, or there is effusion but not bulging, or mildly red tympanic membrane. What you have to do? We have to think in this case that this is just a viral infection, especially respiratory syncytial virus, okay, influenza virus or other infection. Reassess the child in such a case in 24 to 48 hours. If not clinically improved, or earlier if clinically worsening, to verify presence of effusion and signs of medullary inflammation such as bulging tympanic membrane. Okay, so remember that if there is no tympanic membrane effusion, or if there is no bulging of tympanic membrane, or the membrane is not red, very much red, so what we have to think that this is a viral case. In such a case, we don't have to even talk about antibiotics because it's viral. Okay, in such a case we have to just reassure the mom, reassess the child. So yeah, we have to reassess the child in 24 to 48 hours. We have to see if the child is not improving. Then we have to look again the tympanic membrane for presence of any effusion, inflammation like bulging or something. But we have to just reassure the children parents, and then that's the end of the today's topic. That is a very important topic, otitis media. Okay, and if you get any questions from this topic, I hope you will remember all the management guidelines for this topic. Okay, and I will continue next with other infections in my next video. Thank you so much for being with me. Have a good day. Take care. Bye guys.